Welcome back, everybody. We're going to get into upper respiratory infections. This is going to lead into our lower respiratory infection lecture. We're going to talk about upper airway inflammation and bacterial causes and viral causes throughout this lecture. And make sure that you guys are really focusing on that too for your studies on what could be bacterial and viral. Okay, so we're going to talk about one of the more common viral infections, which is influenza, also known as the flu. It can cause very severe symptoms, specifically if this goes untreated. And there's a lot of disease processes out there that present like flu-like symptoms that are actually much more adventitious to us than the actual flu itself. And you guys will get a little bit more of that when you guys listen to your lower respiratory infections lecture. This affects everybody, right? Nobody is immune to the flu. It's going to attack everybody at all ages, at all races, at all genders, and all ethnicities and all comorbidities, right? Geriatric and pediatric patients really do cause the high risk, just like with everything else. As far as complications, we are seeing increased hospitalizations based on the flu. I think that I don't want to get on my soapbox or anything like that, but there's a lot of people out there that do not believe in getting the flu vaccine. I'm kind of one of those people. I think that I understand why people do get the flu vaccination, and I do get the flu vaccination too. I think sometimes it's good to not just get the vaccination, but to just get the flu in order for your body to create those antibodies and the white blood cells in order to recognize it when it comes back to haunt us. Possibly even the next year or a couple years later. The problem with the flu, right, is basically that influenza is a big component of, big component of the actual coronaviruses themselves. If these go untreated, any one of the coronaviruses will lead to a pneumonia, which will then eventually really quickly lead to death, such as like a SARS, right, or an ARDS, and we're going to talk about SARS and ARDS in our lower respiratory infection lecture. So continuing with influenza, there's basically three types, and they're designated as A group, B group, and C group, or type A, type B, and type C. Type A and type B are responsible for epidemics, right? Epidemics of respiratory illnesses that occur pretty much every winter, right? And really, it can go into a pandemic. And if you guys really think about it, right, like the flu affects the whole world every year, right? And because we have that global component, that's why we can be dealing with a pandemic, right? So even though we say that it's an epidemic, really, every year that the flu is here is basically a pandemic because it does spread pretty much all across the globe. It might not hit every single country like a true definition of a pandemic would, but it will spread throughout the globe basically every year, okay? Then we have type C influenza, which is very mild respiratory symptoms, which really has no symptoms at all, right? You might get that kind of severe cold, right? Where you guys kind of have, like, you guys are a little sick, maybe a little short of breath. You're just not feeling, you're feeling kind of bleh, you know what I mean? And then maybe like one night you might have like a little bit of a spiked fever or kind of a low grade fever, and then you kind of sleep it off and everything kind of goes away. That would be your type C influenza. So some physical findings, right? Look, you guys have all had the flu at some point in your life. You guys know exactly how you feel when you guys have the flu. Myself, I'm a big baby when it comes to having the flu, right? I want my blankie. I want some hot tea, right? I want to be left alone. I want to stay in bed, right? And I really just want to be a whiny, full-grown adult male. That's what it comes down to, right? And the physical findings really with flu, you get that rapid onset of a high fever, right? Everything's chilling, right? All of a sudden, you might start getting tired or something like that, and you could just feel that high fever kind of come on. And you guys know exactly what I'm talking about, right? Headaches. We could have a very clear nose, right? And we can have that clear nose basically because we are starting to become dehydrated because of the fact that we're running such a high fever. Sneezing, cough sometimes can be severe. Those body aches and pains, right? We just feel like crap. It could be for days, it could be for weeks. Just really tired, kind of irritable. We could sometimes develop a sore throat. Again, usually that's because of dehydration, guys. Make sure you guys are drinking fluid once you guys get the flu. And you're just tired, right? Usually, on average, the body aches usually last anywhere between 3 and 5 days, but the actual cough and some of the other symptoms can continue on for weeks after the actual true peak of the virus. Okay, guys, some concerns for EMS. This first bullet point is hopefully for you guys at the paramedic level now a no-brainer. Unfortunately, I had to put this in here because National Registry requires us to make sure that we cover this statement with you guys. Yes, aspirin should not be given to children, period. Okay? Just stay away from it, all right? Usually the new vaccine is introduced each September, and of course they obviously do that because here in the U.S., that is usually the start time of when that influenza virus is going to come and rear its evil head, okay? It's about 70 to 90% effective in preventing or reducing the actual symptoms of the flu. We want to limit our contact with infected people. We want to make sure that we're washing our hands and making sure that we are covering our cough and sneeze. And remember, that's both us and our patients, okay? If you have a patient that is coughing, right, it is good medical practice to just at least at a bare minimum put a surgical mask over them so that this the actual spores of the virus don't be released and possibly you guys getting sick as well. Okay, moving on into sinusitis. This is just an infection of the sinuses. It's not contagious at all. However, if this goes untreated, it can actually lead into flu-like symptoms, or possibly, depending on when you actually get the sinusitis during the time of year, it makes you more susceptible to actually getting the flu. Sinuses, they suck, right? I hate my sinuses. I'm a big neti pot fan, where I practically drown myself in order to get all my boogers out and whatnot. But I get sinusitis at least maybe one good one a year, we'll say. My sinusitis usually starts in the fall when everything kind of starts dying off. That's usually when my allergies really kind of kick in for me. And sometimes, you guys might get them in the spring or fall or whenever whatever decides to start popping up and growing. But it is not contagious. Usually it's that runny nose or cold symptoms anywhere between 7 and 10 days. Usually you have that post-nasal drip, right? You guys keep swallowing your boogers even though you really don't want to. Headaches for us, not necessarily in children, due to the inflammation and all the nerve endings that we have in our face as adults. We can develop headaches. Not in younger children because they're technically not really fully developed quite yet, but they will definitely have more of a runny nose than adults will. You could have that facial discomfort, right? It kind of hurts to kind of touch your cheekbones, right? Your eyes kind of hurt. You can kind of feel the pressure behind your eyes. It can lead to bad breath, right? Because you're not really filtering out all that nasty stuff that you're breathing in. So we don't have a way to actually, when we do have that inflammation with the sinusitis, it can lead to that bad breath symptoms. That cough, it could be clear to very thick green or yellowy, kind of boogers that were phlegm that we're kind of coughing up. If we let it go too long, we can develop a low-grade fever. And again, if we let this go too long as well, and depending on the type of year, this can really make us more susceptible to influenza symptoms. We can get that sore throat just with the dryness, right? Our sinuses, all that fluid is kind of going to try to combat our sinusitis, and it's just not working. Make sure you guys are staying hydrated if you guys get this. And swelling around the eyes, usually kind of worse in the morning. You guys get all those nasty little eye crispies, right? That you got to kind of scrape out of the corner of your eyes and whatnot. And usually this can be handled by an urgent care or possibly the patient's primary care physician. Okay, when we're talking about pharyngitis and tonsillitis, this is usually bacterial in nature. Um, it's bacterial usually in the winter. It can be viral when it's more common in summer and actual fall. And this is basically just an infection of the actual lining of the throat and your tonsils themselves. You do have that sore throat with a fever. It could be either high grade or low grade. Headaches. We have the decreased appetite because it hurts to swallow, really, when it comes down to it. We just kind of have this blah feeling. Could have nausea, vomiting, GI upset, right? Basically, in general, you can put all that into GI upset. We can have that kind of visual redness in the back of our throats, right? And obviously, if you guys do go to the urgent care for this, they're going to do a swab to rule out strep. Usually, again, this is something that can be taken care of by your primary care physician or an urgent care. Your next upper air respiratory infection that we're going to talk about is epiglottitis. It is bacterial in nature. It's extreme swelling to the epiglottitis, and it can actually cause a partial upper airway obstruction. Usually very common in younger children, anywhere between 3 and 7, but it can also affect adults as well. One of the big things with epiglottitis is that we want to try to keep our patient calm, specifically our kids, due to the fact that this is closing up. And remember that the epiglottis is the actual only thing that protects our trachea, or the only thing that protects food from going down our trachea when we actually go and swallow food. And what we really don't want to do is get our little ones that are suffering from this, right? We don't want to get them riled up and have them crying, because we don't want them to actually irritate the lining of the epiglottis more, to where we can actually turn that partial airway occlusion into a full-blown occlusion. Some of the classic presentation that you're going to see with epiglottitis, you're going to have that fever, very severe sore throat. You're going to have that dysphagia. They're going to have a hard time swallowing, so more than likely they're going to be drooling pretty proficiently, okay? They might have a muffled voice, right? You can actually maybe even possibly start hearing stridor with this, depending on how much this is actually swelling up in the airway. They're going to have difficulty breathing. They usually prefer the tripod position, and I believe they prefer that because they're drooling so much. They're actually just kind of letting that drool kind of come out of their mouth while they're in the tripod position. Again, we want to encourage the patient to stay out of that tripod position, and then we can also see possible signs and symptoms of cyanosis as well. I do think that we as EMS providers really need to see epiglottitis as more serious as we do. I think that the big thing with epiglottitis, specifically for paramedics, is a lot of the times that we actually see these epiglottitis patients. It's when we're doing interfacility transports out of an urgent care to possibly like a general peds unit floor for further treatment. But this is a life threat, guys. We are occluding the airway. Even if it is a partial airway occlusion, it is still a life threat. About 8 to 12% of the patients that actually get diagnosed with epiglottitis will die due to an airway obstruction, okay? The big thing is we do not want to attempt to visualize the airway. Once again, we do not want to try to get our patients upset, whether they're kids or adults. We don't want them screaming, specifically with kids. I guess your adults can scream too, right? But we don't want them doing that. We don't want them to keep irritating the lining of the epiglottis from them actually screaming. And we want to make sure that we kind of check ourselves, right? Kids are great at reading people, okay? They know when you're upset. They know when you're scared. Okay? They have this really innate ability in order to figure that out about adults. All right? So we need to keep ourselves calm in order to keep our patient calm. All right? One of the best treatments, again, nice, calm, smooth, steady transport. There's really no reason to be going code 3 with these patients, right? We don't want to get them upset. We want to keep them warm. If they're running a fever, we want to make sure that we don't keep them too warm, right? Make sure that we bring mom or dad along, okay? And have this talk with the parents as well, right? We have to have that talk with the parents that, look, they're going to read your signs, okay? I need you to be as calm as possible, okay? Yes, your child is sick, okay? Yes, your child technically has a partial airway obstruction, because they do, right? We're not sitting here BSing the patient. We're not sitting here BSing the patient's parents, okay? But we have to have that conversation so that everybody's nice and chill. Everything's good. We're going to have a really smooth ride to the hospital, and we're going to put them on or continue the oxygen therapy, whether you're coming out of the urgent care or out of somebody's home, okay? Humidified oxygen is the best, and if we can cool it, that's even better, okay? So, hook up the nebulizer. Kids kind of get scared about the nebulizer. Just try to do it a blow-by, right? Throw in some saline in there and have it nebulized, and try to keep that mist as close to their face as possible. Don't necessarily have to throw them on a mask to do this. You guys will learn all kinds of different tricks of the trade in order to keep that blow-by oxygen towards them. And then if we need to, we can also nebulize some epinephrine for these people in order to help with the actual inflammation of the epiglottitis. When it comes to treatment for epiglottitis, most of the time endotracheal intubation, unfortunately, is not an option. Okay, if we do have to go down there and visualize the airway, remember that we are going down there with a metal object, whether it's the Miller or the Mac blade that you guys are using, and as soon as we touch that area, it's going to become more inflamed. Okay, we can't use CPAP on these patients because they're drooling. They're really technically not protecting their own airway. So if we do put them on the CPAP, we're just going to throw that fluid right down into their trachea, and we can cause an aspirated pneumonia that way, right? So if it is that bad and we do have to hustle, absolutely take your blade and see if you can get in there. Be very careful, very smooth. Try not to touch too much of the actual lining that you have to. Make sure that you have the patient positioned in the sniffing position before you even attempt this. Make sure that we're doing some blow-by oxygen, or if we have to, pre-oxygenate with the BVM, and just be very smooth and calm with your intubation if it comes down to it. If we can't do it, unfortunately, a cricothyrotomy is the only way that we're going to be able to go. We have to bypass that epiglottitis, do a direct line into the trachea in order to get an airway. Make sure you guys look back over your cricothyrotomy guidelines and your respiratory guidelines that were given to you in class. Plus, they're in your Blackboard shell as well. Let's start some fluids. They're drying up, okay? And last thing that we want is very sensitive tissue to become more irritated because it is starting to dry up. We want to try to avoid sedatives because we don't want to suppress the respiratory drive on these patients. And again, keep your patient as comfortable as possible and try to avoid any kind of unnecessary examinations. Okay, so croup, all right, it's also known as laryngotracheal bronchitis. I love to play hangman with my boys, and that's one of my favorite words to play hangman with. They hate me every single time I whip it out, but I'm not going to let my kids win, right? Period. They're not going to beat their old man. But anyways, it is known as croup, but the actual medical terminology for it is the laryngeotracheal bronchitis. It is a very common syndrome of an upper airway obstruction. Okay, it is viral in nature. It's also known as the parainfluenza virus. You guys can check that out if you guys do kind of studying outside of your lectures. If you guys Google it, you guys can read a bit more on that. I'm not going to spend too much time on that for you guys. The problem is with it is we have subglottic edema. Okay, so our actual larynx and our trachea and our main stem bronchi are becoming edemic. Okay, usually occurs between 3 months to 4 years of age, and they have that seal-like barking cough, right? And a lot of times, croup is mistaken for whooping cough in some of our patients. They could have low-grade fevers with this. They could go up to high-grade fevers with it if it comes down to it. Most of the time, it's going to be very painful for them to talk, and they're going to be pretty short of breath as well. Okay, laryngitis, it's the inflammation of the voice box, usually because of overuse. Could be because of irritation or possibly some kind of infection. Physical findings with this, we could have a fever present. We could have some kind of persistent cough, or even similar to like whooping cough, kind of like a barking cough in our adults. They could be breathing a little quick. They could be breathing a little shallow, so we can have that tachypnea or possibly and tachycardia as well. Use of accessory muscles. They could have diminished breath sounds. They could be kind of pale or cyanosis. They can be coughing up blood just due to the actual irritation of the larynx. They can be irritating it so much with their coughing that they could start popping some capillary beds down there, and they could actually cough so much with laryngitis that they can actually create a rib fracture, which can obviously hinder their breathing even more just because of the pain from that. The other thing that can go on is because that they're so tachypnea and tachycardic, and because of the fact that they are coughing so much, they can actually have bloodshot eyes, or that petechial hemorrhages, because of the actual irritation of the larynx, and the fact that they are that the irritation is so much, and because of the coughing, that it's actually irritating their eyes as well. These patients benefit very much by nebulized epi, and we need to make sure that we're getting some IV fluids on board, because these patients are dehydrated. Hopefully you guys are starting to see kind of a theme with these treatments. And then if that patient is doing nebulized epinephrine because of their short of breath, if we can also try to help them kind of coach their breathing as well, get in front of get in the face, make eye contact with them, and really kind of teach them how to breathe, is very beneficial for them. And then after that nebulized epinephrine, I would definitely throw them on some humidified oxygen. If you guys don't feel like you need the nebulized epinephrine, just keep the humidified oxygen on them. Hopefully it's nice and cool as well, just to kind of keep the irritation down at the larynx.